do have some additional registrants, so I expect people to come in and join us as we go. But as I say, I just want to move along promptly at 2. So I want to thank you for joining us as part of our RNAO, Parkinson Society, CNO webinar series. Today we're going to be looking at physiotherapy and exercise, and we're very excited to have Kirsty Renica with us, who is very familiar with the subject matter, and we'll go through things. I know that we have some mix in our audience today. Generally speaking, this is targeted for staff in long-term care, but I know that Kirsty is going to share a few caveats around that with us, so I shall leave that to her. Just want to note that if you do have any questions during the session, please just feel free to use those, to enter those in the chat box that some people are taking advantage of now in the lower right-hand corner. If you have further questions that aren't explained during the session, please feel free to email either Heather or myself, and Kirsty's going to share her contact information as well later. But please do use that chat box for any questions or or any questions that you have, pardon me. One thing, of course, to check as we're going forward is the volume bar on your speakers. Everything mostly coming through on my test equipment now, so hopefully it is on your end as well. And again, we'll be attentive to the volume of our speaking if you'll be attentive to the volume of your speakers, and hopefully this works well for everyone. If it fails, I should note that it is being recorded as well, so we'll make that archive session available to everyone to listen to at a later date. Heather, I believe this is where I turn it over to you.
Great, thanks, John. I'm Heather Woodbeck, and I'm the Best Practice Coordinator for Long-Term Care for Northwestern Ontario, and I'm really excited to be part of this webinar. Just to say a couple words about best practices that apply for people with Parkinson's and that relate to exercise. So first off, our objectives for today are to share best practices for resident-centered care for people with Parkinson's disease, to provide an overview of exercise in Parkinson's, and to discuss appropriate exercises during the continuum of Parkinson's disease. In long-term care, we have what we call the Resident's Bill of Rights. It's part of the Long-Term Care Act. And so every resident has the right not to be neglected, and then the right to be provided to receive care and assistance towards independence based on a restorative care philosophy, and hoping to maximize their independence to the greatest extent possible. So this is where this exercise is so incredibly important, and those of you who work in long-term care know that we've gone through a lot of changes with the physiotherapy in the last year, and so this is where we're hoping to bring this information to you to help optimize the exercises for your residents who have Parkinson's. And as Kirsty's going to explain to us, things change as the residents' Parkinson's progresses. On the next couple slides, we have a couple of best practices that really apply to this situation. And one is the prevention of falls and falls injuries in the older adult. And you can see that two of the recommendations, one that nurses support physical training as a component of a multifactorial fall intervention program is a recommendation, but it also says taking into consideration client risk factors. So this is what I'm hoping that Kirsty's going to share with us today, some of the risk factors that we need to consider for our residents who have Parkinson's disease. And that the next one is that all residents who have been assessed at risk receive education about their risk. And so again, this is looking at did you just back up there, John? Looking at some of the risks that might be there for a person who has Parkinson's disease. Then just now we can go ahead, John. Thanks. The other one, best practice that this really applies to, is the prevention of constipation. And so you might think this is a bit odd, but the use of physical activity is strongly recommended. But physical activity needs to be tailored to the resident's their physical abilities, their health condition, things they like to do, how feasible is it to help them adhere, and then looking at things like frequency, intensity, and duration it's based on client's choice. And then there's even a second tier of recommendations. That's on the next slide, John, around constipation. And so walking is recommended for individuals who are fully mobile or have a limited mobility. So in long-term care, this can be like helping them walk to the dining room, helping them walk around the unit that they're on, or ideally getting them outside. So trying to get people to walk at least 50 feet twice a day is recommended for people who have limited mobility. And this, again, helps to improve the constipation and is one of the main things contributing toward it. And then we get to, this might be at the later stages of Parkinson's, where people who are unable to walk or restricted to bed, doing things like pelvic tilts, leg lifts, those kind of, and low trunk rotation, those kind of exercises are what can really help to keep their bowels mobile and keep things going. So without further ado, I'm going to turn it over to Kirsty, who has all the really good stuff we want to hear. Oh, sorry. There's a toolkit that you can use. Sorry, I forgot my last slide. That has information on falls prevention and has more on constipation and continence, and as well, that you can go to. There's the website address that can give you some more resources.
And I actually have one additional slide as well. I know that Kirsty references these during her session, so I won't go into great detail, but the Canadian clinical guidelines have been developed on Parkinson's for physicians largely, but for staff working in long-term care and physicians. They do have a very specific reference to physical activity and exercise, and just note that indeed they should be available for people with Parkinson's across all settings, with particular consideration given to gait re-education, issues around balance and flexibility, aerobic capacity, movement initiation, focusing really on functional independence, so those exercises that aim to restore mobility and activities of daily living, and of course advice, and in a long-term care setting, the opportunity for safety in that environment. So now, without further ado, we will indeed turn it over to Kirsty.
Hi, everybody. I just wonder if my volume is okay. If it's not, maybe give me some feedback on that before I go any further.
You sounded pretty good there, Kirsty.
Okay, good. Love all this equipment around me. So I'm going to introduce myself and tell you a little bit, I guess, about what I think you were hoping to get out of today's session. So we could go to the next slide. But we're going to talk about basically advanced Parkinson's disease, physiotherapy, and exercise, because they aren't exactly the same thing, and I know there's some confusion about that. So just some quick objectives for the session today. And I don't have a whole pile of slides because I'm hoping that there'll be some discussion points. So I want to leave some time at the end for that. So basically, just some introductions. I'm going to introduce myself a little bit and why I think I was asked to do this session. Also, I wanted to get a sense of who's in the audience today. Quickly do an overview of Parkinson's disease. You're all here, so my assumption is that you know some about Parkinson's disease. So I'm going to quickly review some of the hallmark features of Parkinson's disease and then the stages across that continuum. Talk about the benefits of physiotherapy and exercise at each of the stages of Parkinson's disease. Give you some tips and tricks that have worked for myself and my clients over the years, and that are also recommended in some of the best practice guidelines, and then give you a couple of quick resources, otherwise known as references, and then I'm hoping to leave about 15 minutes for questions and feedback. So hopefully that's what you thought you were signing up for, because that's basically what I've got for today. So moving along to introductions, just quickly about myself. I am a physiotherapist by background and training, and I did my master's in public health a few years ago now, and really that my master's focused on Parkinson's disease, specifically the autonomic nervous system, which, don't worry, I'm not going to tell you about today very much, but the more exciting piece for me was that with my colleague and support of the local Parkinson's support group and Dr. Jog from Western University, we developed a community-based exercise program for people living with Parkinson's disease, and that was something that the local support group really felt that was necessary, that they wanted something to be something available to them that was specifically targeting people with Parkinson's disease and their common impairments and functional limitations, but not in a hospital setting, so post-rehab. So that was very forward-thinking of them. So right now what I do is a whole pile of different things that I'm not going to bore you with. The main thing that would be of interest to you folks is that I'm currently the coordinator of our community-based exercise programs for people living with chronic neurological diseases, and one of those is, in fact, the Parkinson's class, which is still going after that pilot study about 8 years ago now, that's pretty exciting for us. So really, that's what my interest in Parkinson's disease is. I've got some personal family history with Parkinson's disease, and then also just working with this population over time, and really just seeing the need to incorporate physical activity and options for people living with Parkinson's disease right across the spectrum of the stages of Parkinson's disease. So that's sort of it in a nutshell. Again, my focus right now is pretty much community, but in the community, of course, we've got quite a wide variety of folks living with Parkinson's disease at various stages. So that's that in a nutshell. So I had asked John if we could do a quick poll and just get a sense of, are you a person currently living with Parkinson's disease or working as a healthcare provider with people with Parkinson's disease? And if so, are you in the long-term care sector, which is what I would expect the most people, but to respond if you're a healthcare provider. But also I was interested to know if there was anybody attending that worked in another sector.
So, Kirsty, you see that we do have that poll open and are collecting some votes.
I do. So thank you very much.
As we allow people one brief moment to respond to that, I thought I'll take you aside. Can I ask that you attempt to control the session, if you're comfortable with that, with the left and right arrows on the lower level?
You bet.
Just noting that you have the transitions with each bullet point. I'm afraid that I can't keep up to you as well as you can, so we'll let you try that.
Sure, that's fine. We'll see if I can keep up with myself.
A better chance than me. Thanks.
So what I'm seeing from the poll, just as it's coming in, is that we've got a few people who either are living with Parkinson's disease or are a care partner, but the bulk of the folks today that are in attendance are healthcare professionals in the long-term care sector, which is what I expected. Great. Oh, but we have a dancer volunteering with Dancing with Parkinson's. That's great. That's wonderful. I knew that other category. It was always interesting. So thank you very much. As I said, I'm going to do an overview across the spectrum of Parkinson's disease. So we will be talking about some of the other stages of Parkinson's, not just long-term care, but that's where we'll focus the bulk of the discussion today, and that seems like it would be appropriate. And I see we've got somebody else, another personal trainer in chronic care management. Wonderful. Okay, so I think that's all I'm going to say about introductions, and I will try to keep myself on track. So just basically an overview of Parkinson's disease, and this might be repetitive for some people, so we'll go through it fairly briefly. But Parkinson's disease is a chronic progressive neurodegenerative disease. I think the key thing that I like to think of as a physiotherapist is that this is a chronic disease, so it's, someone's going to be living with Parkinson's disease for quite some time. So that really forces us, regardless of the sector, to really think about people over a longer period of time, and not just sort of that quick acute care visit or that one quick assessment in and out. So that's what makes me kind of jumps out at me about that definition, as well, unfortunately, the progressive nature of the disease. So the hallmark or cardinal features are a resting tremor, and this is a pretty distinctive resting tremor. It's a pill rolling tremor. So it's not just your standard sort of a person's got kind of a fluttery hand, or it's very distinct where the hand is actually turning and rolling as if there was a pill between the thumb and the forefinger. So it's quite a distinctive tremor. Bradykinesia, which is the slowness or poverty of movement, so things start to slow down, or the movements themselves become very, very minimal. So where you see that are things like slower steps, shorter steps, just even in terms of arm swings and things like that. All of the movements tend to get a little bit slower and lower in amplitude. Rigidity is another one of the cardinal features. So again, really a tightness overall, particularly in the trunk. And where that's important for caregivers is particularly in things like tasks where you might want to do, say, rolling over in bed. Becomes really difficult to disassociate the shoulders from the hips. So something we would take for granted, those of us without Parkinson's disease, just quickly rolling out of bed, a person with Parkinson's disease really struggles with something like that. You also will see that rigidity impact gait because you see a loss of arm swing and, again, a loss of trunk rotation in the walking, so that rigidity. And the final sort of cardinal feature is this impaired postural reflex. So this is really important in terms of balance. So not being able to right oneself if they're pushed or shoved. Then, of course, we're trying to do that in a standardized fashion, not just gratuitously shoving people with Parkinson's, but basically not being able to regain balance. Other common motor impairments, so very common but not necessarily those cardinal features. This festinating gait, so that's that shuffle, shuffle, shuffle when you see people walk. And it's more than just what you might see in another older adult who maybe has some muscle weakness. This festinating gait is basically not being able to catch up with themselves. So once they get started, just kind of rapidly keeping going with these small steps, and of course that can be a big fall risk because they get going and keep going and keep going and keep speeding up and with those small steps and trip over their own feet. Micrographia, which is very small writing, and a lot of times folks in the early stages of Parkinson's, this is one thing that they'll note when they come to see me or another one of the healthcare professionals. Just it seems like an odd thing that popped up, or when they do get their diagnosis of Parkinson's disease, they say this is one of the things that they did notice early on before their diagnosis was that their handwriting just got smaller and smaller and smaller and smaller. Another one of the common motor impairments is this freezing during gait, and that's probably one that people are very familiar with. So starting to walk and then all of a sudden just stopping and not being able to reinitiate and get going again. And that freezing can happen for lots of different reasons. Could be that there's a line on the floor and that becomes a visual barrier for people, but again, quite common motor impairment with Parkinson's disease. So again, when we think of those motor symptoms, festinating gait, I already talked about the micrographia, the freezing during gait. There's an awful lot of non-motor symptoms as well, and these tend to be probably things, I would say in a general way, that you're going to see in the later stages of Parkinson's more often. However, they're probably, this is my own personal opinion, so I put that out there, probably not as well or as easily managed as the motor symptoms, but can be quite distressing for people living with Parkinson's disease and for yourselves in supporting folks with Parkinson's. So non-motor symptoms, depression, dementia, hallucinations, which tend to be medication-related and not themselves a byproduct of the Parkinson's disease. And then I told you I was going to briefly talk about the autonomic nervous system, and don't worry, you're not getting a lecture on that. Nobody wants to hear about that, about my thesis, including my family members. But some of the things that fall under the autonomic nervous system would be orthostatic hypotension. So that would be important for yourselves to know as care providers, regardless of the setting. Just that fall in blood pressure as people move from a lying to a sitting position, or particularly, but also can happen with sitting to standing. So it's this drop in blood pressure. People can then, that can cause falls, just dizziness, disorientation. So that this orthostatic hypotension is something to watch out for, particularly in the population of people living with Parkinson's disease. Thermal regulation, it's quite interesting. We'll get people exercising in our community group at a fairly high level, I would say, and nobody's sweating. They're quite tired, and they feel like they're really exerting themselves, and I can tell they're exerting themselves. But in terms of sweating or maybe shivering when they're cold, this can be a problem for folks with Parkinson's disease. And while it might be nice not to sweat or shiver, in terms of a response to exercise, it can be detrimental for people. Cardiovascular response is diminished as well in people with Parkinson's disease. So again, like I said, with the thermal regulation, people can be exerting themselves quite a bit, but actually their heart rate doesn't necessarily rise to meet the demand. So that's something to be aware of, that they are feeling fatigued, and part of that is that cardiovascular system is just not keeping up with the demand there. And then others, so some issues around things like impotence, etc. So as you can tell, certainly as a physio, we focus a lot on the motor symptoms. You could see those non-motor symptoms would be quite bothersome for folks, and something to be aware of for yourselves in supporting people living with Parkinson's disease. Falls, Heather already mentioned falls right at the very beginning, and so I thought it was worth putting in a slide specifically about falls. Falls are extremely common, unfortunately, in people living with Parkinson's disease. So I've given you a couple of different stats, and I wasn't going to bore you with that, but basically tons and tons and tons of literature around fall rates and people living with Parkinson's. So some of the stats 5 times higher overall than people who do not have Parkinson's disease. One recent study, I think it was from 2002, it's in the reference list, but they found over a year it was 68% of community-dwelling people with Parkinson's disease had a fall. Anyway, a significant source of, obviously, injury for people, and then something we want to be aware of, particularly in that long-term care sector, when we know that these are the kinds of things that can result in hip fractures, surgery, and poorer outcomes, just because you've got a frailer population already at risk of falls, and then the Parkinson's on top of that is contributing as well to risk. So some of the risk factors specifically for people with Parkinson's disease, multiple medications. That's actually for any population, but that's been borne out in people with Parkinson's disease. So those people with Parkinson's that are on 4 or more medications are at higher risk for falls. So again, if we're starting to think about that population in long-term care, those folks often have other comorbidities, and so are often taking more than, they're often on more than 4 medications or 4 or more. Muscle weakness, that's a global risk factor in older adults, but specifically also in people with Parkinson's disease, as well as gait and balance impairments, which I talked about a little bit already with the festinating gait and the freezing. Those are sort of specific to people with Parkinson's disease and contribute to their risk factor. Hypotension, so that, again, that orthostatic hypotension, and then as with most populations, increasing age and increasing stage of disease also contributes to a higher level of risk for falls in this population. So again, probably of particular interest to the folks here today that are either supporting somebody with advanced Parkinson's disease at home or in long-term care. So physiotherapy and exercise, and I'm going to just put up all my stuff right now. So why I'm doing this is because, of course, I'm a physiotherapist, and I know that there is some a little bit of confusion sometimes about the difference between physiotherapy and exercise. And with the physiotherapy reforms that came into place starting in April but were enacted in August, there have been some changes to long-term care in terms of how these services are delivered, so I thought it was pertinent. So physiotherapy involves the assessment of neuromuscular, musculoskeletal, and cardiorespiratory systems and the diagnosis and treatment of physical dysfunction, injury, or pain, and it has to be from a regulated physiotherapist who's registered with the College of Physiotherapists of Ontario. And I pulled this particular definition off the Ministry of Health website because, again, just related to the recent physiotherapy reforms. So the key features of this are that the physiotherapy, when somebody's referred for physiotherapy, you should expect to see an assessment that the treatment plan is going to be goal-oriented, and realistically it's likely to be time-limited. That doesn't mean that the person might not need another referral, or the physiotherapist might not come back to see somebody for another issue, because we know folks in long-term care often have multiple issues. But again, really goal-oriented, and then this assessment piece are critical. The difference with exercise being that physiotherapists might use exercise as one of the modalities to treat and try to hit the goals of the patient or client, but exercise is physical activity that's planned, structured, repetitive, and has a final or intermediate objective that which is the improvement or maintenance of physical fitness. So it's more of a component that might be incorporated by physiotherapy or physiotherapists, but isn't physiotherapy per se by itself. And certainly you'll see that with the physio reforms in that there's funding specifically allocated to physiotherapy services, and then the pocket for, or the envelope of funding for exercise classes that are likely not being led by a physiotherapist, but perhaps by yourselves. So I just wanted to do that quickly because that's probably where you've seen some changes in your facilities. So the stages of Parkinson's disease, I just thought, again, I'll start with the beginning, which is mild. So symptoms, people are usually quite aware that they are having some kind of difficulty, but the symptoms are mild at this stage. So they might be inconvenient. So again, oftentimes what people will first notice is that very distinctive pill rolling, single-sided hand tremor. So that's, again, in the mild stages of Parkinson's disease, you're seeing one-sided motor symptoms. And again, oftentimes it's this tremor, not always, but and people find it embarrassing, but it's not necessarily affecting their daily activities. They might choose to use a heavier mug, for example, or keep their hands in their pocket, or that affected hand in their pocket more, that kind of thing. But the person themselves is generally noticing that some things have changed. And the medications at this stage are generally quite effective regarding the movement symptoms, so specifically for tremor, for example. Some of the non-medication related treatments that would be very appropriate at this stage, and I should mention here that I'm getting this from the clinical practice guidelines, Canadian and European, etc. So I'm not just making stuff up. You'll be glad to know. But so one of the things at this stage is regular exercise, which of course is going to be appropriate for anybody at any stage along the continuum, to the best of their ability or functional capacity. So maintaining the point of, or the purpose of exercise at this stage would be to maintain or even improve someone's mobility, because again, we've already talked about cardiovascular difficulties, etc. So again, if we can get folks to their highest level of physical functioning at this early stage, they've got a little bit more room to maneuver, as the disease unfortunately progresses. So again, goals maintaining or improving mobility, flexibility because, again, of the rigidity that comes along with Parkinson's disease, that cardiovascular fitness that I already talked about so that we can get people, again, as fit in a cardiovascular capacity as we can. Range of motion, again, sort of speaks to that rigidity piece. and balance. And where we're going with balance is people are probably already starting to see some changes, and we really want to nip this balance stuff in the bud as quickly as we can. So really targeting that falls prevention at this piece while we have a really good opportunity. Also, lots and lots of literature on the positive impact of physical activity and just general regular exercise on depression overall and constipation, which was already mentioned. This is a stage where I think you would probably want, and of course I'm going to say physio at all stages, but this is where you would consider a referral to physiotherapy when someone has some specific issues. So I'll often see someone who has just recently received a diagnosis of Parkinson's disease, so we might talk about some self-management things like getting into a regular exercise routine, talking about some of the difficulties that they may experience, some things they might want to consider. And at this stage, we can really talk about cueing strategies, which would be things we'll talk about a little bit more detail later, but things like counting 1, 2, 3 if they're starting to feel like they're getting blocked or locked. They're probably not having a lot of freezing episodes at this point, but they might start to feel that hesitation. So some cueing of things that they can do themselves, counting when walking. There's some really neat stuff happening out of the University of Alberta on using iPods with built-in metronomes, etc., for improving of gait, particularly in this early stage. And then dual tasking, which is basically trying to, so people with Parkinson's disease as a result of their disease process have difficulty attending to more than one task. And while some of you are saying, so do I, this is quite marked in folks with Parkinson's disease. So actually training dual tasking can be quite helpful. So things like getting a little bit of distraction while walking in a safe way, of course. So trying to train that, doing two things at once. And then attentional tasks. So really, instead of, because we can't expect as the disease progresses that all movement is going to be instinctive anymore, starting to really attend to the task. So what are the component pieces, say, of moving from sitting to standing? Getting the shoulders over the knees, scooting forward in the chair. So really breaking down the tasks if they're starting to see that they potentially have some difficulty. At this stage, you're probably not talking about getting out of a chair, but maybe things like they're golfing or what have you. And then falls prevention, just because it's so important, and we can start early with this group. The moderate group of folks with Parkinson's disease are people with at the moderate stage, so this, or the middle stage, depending on your source. At this point, people are experiencing bilateral motor symptoms, so symptoms on both sides of their body. Definitely seeing the slowness of moving, so that change in gait pattern. Usually what you'll see is people will really start to get that hunched over, forward bent position. And particularly in my younger folks with Parkinson's disease, it's quite noticeable because, there's a 65-year-old man who all of a sudden is walking quite hunched over. And so this slowness of movement, this balance changes start to become obvious here. And obviously then balance and coordination difficulties start to begin, partly because of the other issues, but partly also just the disease process itself. This is where, again, you might see that freezing when people are walking, and the medications may start wearing off between the doses, so you're getting that on-off phenomenon for a lot of people. So great when the medication kicks in, and that's actually when we try to get our folks out to our exercise classes. But then, then that medication, say they take their medication at 9 o'clock, they're great from 10 o'clock until 11:30, and then they're waiting for that 12 o'clock dose at noon, and all of a sudden they're just really frozen up. Their walking has deteriorated, all these kind of things, until they get that medication, it kicks in, and they're back in the on phase of their medication. So this is the stage where, again, the medications start to be can be not as helpful, and you just see that on-off phenomenon. So, and this is also because the medication is probably going to start getting increased either in overall daily dose or the frequency during the day. You might also start to see some side effects with the medications. So some of the dyskinesias, so the classic one is when Michael J. Fox was initially diagnosed, you saw he had that chorea, so those sort of what we would call kind of a snake-like movement. So some of these involuntary extra movements coming from the medication side effects. This group also will often complain of pain in the morning, so that's something to be aware of for yourselves in supporting people with Parkinson's disease, because again, maybe the medication is worn off overnight, and so having some of these problems with the dyskinesias, leg cramps at night, so in the morning being somewhat uncomfortable again until the medications are on board. So some of the treatment strategies at this stage, so regular exercise for all of the same reasons we talked about as above, and here probably looking at physiotherapy more to target those mobility, balance, and other issues again. Continue teaching on those special strategies, the cueing, the dual tasking. It's going to be particularly pertinent to this group at this stage because they actually are experiencing some difficulties. So whereas in that mild group, maybe some of that rigidity was causing a bit of a hip problem that we can address, using sort of normal orthopedic strategies. At this stage, we're going to be targeting a lot of the Parkinson's kinds of things. This is also the stage where you might consider occupational therapy, so some of those things about maintaining independence, whether that be assistive devices, home modification, things that are just going to make those tasks, those activities of daily living easier for people, and falls prevention. Again, always. And then advanced, and this is really what I think you folks are probably the most interested in. But at this stage, people are having great difficulty walking. They may or may not be walking anymore at all. So most of the sources that you look at it will say at this stage people are primarily sitting or in bed most of the day. They're not ambulating a lot. Generally speaking, not able to live alone because they're needing so much assistance with the activities of daily living. So this is probably your populations for folks who are working in long-term care. This is where we start to see a lot more of the cognitive problems with the hallucinations, some delusions, and this, which is obviously quite distressing for family. And one of the challenging things here is that the balancing the medications and the side effects becomes a lot more difficult. So, you want the person to be ambulatory or as mobile as they can be, but on the other hand, again, having, maybe some of these quite upsetting and disturbing psychiatric kind of issues coming through. So that balancing act becomes pretty important. So some of the things to consider, speech pathology, of course you could consider at an earlier stage if people are starting to have those speech impairments, but specifically here you're going to want to concentrate on things like swallowing assessments as well to make sure that people aren't aspirating when they're eating, good positioning, and considering assistive devices if they don't have them already. I would be shocked if they didn't have any assistive device at this stage, but you might consider advancing the technology that you're using at this point. So maybe moving to that wheelchair or, a more advanced type wheelchair, so some of the tilt wheelchairs, things like that. Positioning, both bed positioning, but also if people are going to be up for a significant portion of the day, which I hope they are, that's really the goal, but positioning in the wheelchair too for comfort, but also so that people can interact in the activities that are happening in long-term care or in their home. Wound prevention and management becomes really important here, and again, as people really advance along the spectrum here, with that rigidity comes along an increased risk of wound development, and also people aren't as mobile, so they're not able to turn or shift in bed maybe as much, or turn or shift in their wheelchairs. So again, that wound prevention is really important. So again, range of motion exercise is quite valuable at this stage, particularly because, and this could be incorporated into just, people getting dressed in the mornings, so kinds of any of the things that you can incorporate during your care routine. And really the idea here is this is going to benefit both the person living with Parkinson, but yourselves as healthcare professionals or people supporting folks, in that it would be easier to do dressing changes, to assist people in getting their clothes on and off, toileting, that kind of thing, if they still have a reasonable amount of range of motion in their joints and limbs. Deep breathing exercises, depending on whether people can follow through, it really depends on the person's stage. But just to keep, again, that lung capacity, as optimal as you can, because, again, a lot of rigidity around the trunk and those postural muscles. So, again, think of that earlier example where we were saying somebody really hunched over. That's really compressing your lungs, making it very difficult to take those big, deep breaths. And so, of course, we are concerned about airway clearance and pneumonias, et cetera, and being able to physically clear something if you actually did end up with some kind of lung infection. General mobility and transfer training. So I know I'm kind of going back and forth with wheelchairs and things like that, but this could be, general mobility could just be practicing that rolling in bed, practicing the sit to stand at this point. So just, standing up, sitting down, and also working on those transfers for the person with Parkinson's themselves, so that they can be as independent as possible, but also to help yourselves out as support people. If your client or your patient is doing more of the work, that means you're doing less of the work. So that's always helpful. And of course, people generally prefer to participate in their own care, and they feel less than like they're being, hauled around like a sack of potatoes or that kind of thing. So good for just, again, general well-being. And then walking is tolerated. So, if people can only walk that 10 meters or 50 feet or what have you, but making sure that they're keeping up with it, so that maybe walking for the sake of walking isn't the goal, but walking for the sake of keeping that body weight on the legs to maintain bone mass, to help assist in maintaining their transfer status, those kind of things. So walking is kind of a one-size-fits-all exercise that hits so many of those targets and the fall risk as well. So that's something to consider, even if people are at that later stage. So basically, I'm not going to talk a whole lot more, and I'm looking at the clock, and I'm actually not doing too badly. And I am going to give you some specific tricks, don't worry. So basically, to sum all that up, pretty much exercise at any stage of Parkinson's disease is helpful. It's just that your goals may change over time. So at those early stages, you're trying to prevent decline. You're probably trying to maximize somebody's performance. As you move along through the stages, again, we're probably going to start to focus on maintaining what they've got and maybe preventing any further difficulties like falls, with that long-term care sector or that advanced stages where we're really, again, trying to prevent other complications like the bed sores and lung infections and those kinds of things. So it's really just a change in focus. So Heather mentioned at the beginning, even folks who, if they can just be up in a chair and doing a seated exercise program, even if it's very limited, they're still going to be up, participating in a class, in a group. So good for their mental health well-being, but also just, again, better positioning for your heart and your lungs rather than being in bed. And just, again, feeling some control over your own personal path. So, again, also thinking of the person with Parkinson's and maintaining as much as possible their ability to complete tasks of daily living. And even if it's not 100% of that task, but it's, again, in those later stages, 25%. So they're able to help you out with the transfer or, assist somewhat in getting dressed or bathed. It just, again, helps with the sense of of well-being. And that overall, again, that focus on function, so including the transfers. So again, I can't say enough about walking, sit to stand, those kind of things, basically getting people up and moving to the best of their ability and with a goal of their function as opposed to maybe maximizing, particularly one joint strength, that kind of thing. So some tips and tricks, and I am actually coming to the end, and I'm actually on time, which is so shocking for me, to be honest with you. And then we'll have lots of questions, or time for questions. So here's just some tricks, and I'm going to give you them all. There we go. So some of the things that work well for people with Parkinson's at pretty much any stage are doing this cueing business, but when people are having a freezing episode, and also before they start a task. So things like, and this is just a very interesting feature of Parkinson's disease, is this idea of a metronome, 1, 2, 3, 4, or row, row, row your boat. Any of those kinds of things that are very repetitive, very like a metronome, tend to help people get out of those freezing episodes. We're not exactly sure of the mechanism, but it works like a charm. And so what's really helpful is if folks learn these tricks themselves so they can help you out. And also before starting a task. So difficulty initiating movement is part of the disease process with Parkinson's. So again, that cueing before starting the task is, one, explaining to your patient or your family member the task that you want them to do. So, for example, okay, Mr. Smith, we're going to move from the bed into your wheelchair. I need to get you closer to the edge of the bed, or we're going to sit up first. That would probably help, but closer to the edge of the bed. We're going to get your shoes on. We're going to take the armrest off. Can you put your hand over here? So really breaking the task down is quite helpful for people with Parkinson's disease. And then that counting, so say moving from, again, sitting at the side of the bed to sitting in the wheelchair, that one, we're going to go on the count of 3 and get the person to count themselves, 1, 2, 3, and go for the transfer. Music with walking, I mentioned that briefly. There's a picture on the bottom right that's actually higher tech than it needs to be, but that's one of the high-tech devices that you're seeing now for people with Parkinson's disease, more for the early stages, but actually has a built-in, uses the person's iPod with the metronome basically built into it. You can actually use some just ordinary running programs do that for people who are training for marathons and things like that. Will often have a pace that they like to run at, so you can even use some of those strategies, free downloads, actually, just to get people walking at a slightly faster pace, with a lot of positive health benefits that we're seeing from that. So that's the music with walking. So just, again, trying to get into a pattern and avoid that festinating gait, so that quick, speeding up gait, and also the freezing episodes. The assistive devices, so I'm sure you folks are very familiar with the various assistive devices, but, using transfer belts consistently. Transfer discs, I've got 2 different kinds of transfer discs on the far right. People with Parkinson's disease generally have difficulty turning, and again, initiating that movement, but they can often stand and help you do the transfer. It's just then to get them to move and turn is quite difficult. So we've had a lot of success, certainly at St. Joe's, using some of the transfer disc type things as well with some of our community folks who can do the pulling up part of the transfer but can't get their feet around. So those are 2 pictures of those. Sliders, in the bottom left, I've got kind of a funny slider that's actually to use, you can use that in your car, so that helps people transfer in and out of a car. I also sometimes just use a garbage bag, to be honest with you. But there's lots and lots of different kinds of transfer aids, transfer devices. Slippery sheets are helpful, probably not totally going to be okay in long-term care, but slippery sheets work quite well for people when they're having difficulty turning in bed or getting that part of the transfer, the bed bed transfers are starting to become difficult for people. The difficulty is, of course, you need them to not slide right off the bed, so shoes and all those kind of things. But if you've got the slippery sheets and maybe a grab bar or side rail that people can hold on to once they're sitting up, they can be quite helpful. Rolling gait aids tend to be better for this population than like a regular standard cane, just because that rolling tends to help with that normal patterning of walking. But I put the slow down brakes, and that's what the picture is in the top left, just to make sure that they're not still rolling. So it kind of slows things down, gives you that nice normal rolling kind of gait pattern, but without the speed that can be a problem or a hazard. So again, just keeping in mind that people often with Parkinson's will often have difficulty turning, so that trunk rotation and starting a movement. Once they get going, they're not too bad, but the starting can be quite difficult. And then sometimes just being creative and looking at sometimes the potential barriers as goals. So a lot of folks that I'll see, they will see a line on the floor in the hallway as a real barrier, and that gets them into a freezing episode. But again, looking at that, okay, there's the line, we're stepping over the line. So using those barriers and changing them from an episode of that's going to be, oh, we're stopping, and we're starting to run into some difficulties and maybe worrying about falling, but actually anticipating it, and we're going to step over it now. 1, 2, 3, and over we go. And then the big thing just at the end of the day is just staying as mobile as possible at every stage along the disease process. Again, for the comfort and the well-being of a person living with Parkinson's disease, but also for yourselves as care partners. Just makes your life a little easier too if people are able to participate as much as possible in their care. So that's, in a nutshell, I've given you some resources there. There's tons and tons and tons of stuff in these guidelines, so you can get a little bit bogged down, but there are some exercise handouts on some of these websites that also gives you some ideas of some of the other professionals you might want to include at various stages, so I thought I'd give you those. And then this is it in terms of I've left some time for questions and comments, and this is me and my contact information. And I think I'll open it up to questions at this point. I'm guessing that people will probably have some specific questions right now.
That's great. Thank you, Kirsty. So anyone that is interested in asking a question, please do so in the questions and comments section on the right. I want to thank you again for sharing that while we're waiting for some questions to come in. Congratulations on staying on time for one thing, pardon me. As you mentioned, it's always a struggle. Thanks for sharing the information on everything generally. Specifically, I think the points on and off times and the challenges of feeling well when exercising and when moving in general, information around falls, the staging overview, and then these tips that we just concluded. Hopefully people will find that very useful in their practice. I see one question that came in just about copies of the slides from the Nipigon Hospital, and I'll note that we're going to make this presentation itself, the webinar, available after the session in a couple of days, maybe by Monday of next week. You'll have an email with that link. And as well, Kirsty, we're going to share a PDF of your slides. Is that correct?
Yes, yeah.
So you'll find that in an email from me as long as you are pre-registered for this session. The next question that's come in, I suppose you can see, in your exercise classes from Golden Manor, what type of exercise are you doing?
So actually one of the things that we did develop as part of that master's piece some time ago was when we were developing our exercise class, what we wanted to have was not just myself and my research partner just training fitness instructors to deliver the classes. So I should be clear, we have fitness instructors delivering the classes. I don't myself deliver the classes. I check in periodically. And what we thought was very valuable, or would be very valuable, is to have a standalone training package so that, if the instructors changed or if I changed jobs, for example, that there would still be that resource out there. So one thing that if you contact me and if you are interested, we do have you could tell the technology is a little old. It's a CD-ROM. That actually is a training guide for fitness instructors who are leading classes for people with Parkinson's. I'll tell you that it tends to be at a higher end because it was geared for people with who are still living in the community. However, there's lots of adaptations that are included. So if you're interested in that package, email me. There's a cost of $20, and that's just for mailing, and because we run out of them and periodically have to make some more. So I'm not getting rich off this. It's a St. Joe's thing. But some of the exercises specifically that we do are, we always start with, we always include a warm-up and a cool-down component. That's the warm-up predominantly would be sort of your range of motion type things, the cool-down being a lot of flexibility. Lots of postural stuff during the class because, again, the posture influences balance so much, and we know fall risk is significant. And then we do a component of upper and lower extremity strengthening. We do some things like weights and tubing and balls and stuff, but a lot of particularly for lower extremity exercises are done in standing. So we're trying to be as functional as possible. So sit to stand exercises. Lots of hip stuff because, again, we're at hip and ankle because, again, we're concerned about targeting those muscle groups for fall risk. So I hope that's helpful. And, again, if you're interested in that resource, let me know. Just get in contact with me about that.
And just another question. Thank you very much, Kirsty. Regarding advice, tips, ideas on finding the right physiotherapist or exercise partner, I guess?
What I would suggest really is, of course, if you can find somebody who's got some expertise in neurology or the neurological populations, you're probably going to be a little bit more successful. Even within some of the orthopedic or private sports clinics, you'll find there's usually somebody who has an interest in the neuro population. So, maybe they predominantly work with people with stroke, but, again, they've got an interest in the population of people living with a neurological disease. So I would start with that. Not a lot of options for outpatient services, physiotherapy services, and quite long wait lists, unfortunately. So that is a gap in the system for sure for people with Parkinson's. But they do exist. Those outpatient services do exist in some of the hospitals as well. But really, you'd be looking for somebody with some kind of background or experience in at least neurological populations.
Thank you. And what I believe to be our final question, and it's a specific question about toe curling, and again, more specifically, about walking with curled or frozen toes.
Well, that one's a little bit of an interesting one. I have seen this happen. It's there's a couple of things that could be going on. One is it could be that morning sort of dystonia that can be quite uncomfortable for people, and sometimes they'll relax over time, but they wake up with these foot cramps. So that could be it. And a lot of times that is really just the medication has to kick in, and they've got to just get moving with their day. And so sometimes just doing some stretching exercises and waiting for the medication to kick in works. I have seen people who unfortunately do end up getting contractures, so they actually can't uncurl their toes. And in that case, you'd be wanting to consult with an occupational therapist, I would say, to look at some specialized footwear because, of course, you don't want them running into wounds. Obviously, the feet weren't designed to be walking on the tops of your toes, so I would be concerned about the safety of that. But there is quite a bit of specialized footwear out there between different population, not necessarily just Parkinson's, but I'm thinking of also the population who lives with diabetes as well, often have some challenges around footwear. So there's quite a bit of interesting stuff out there, but I would say either an orthotist or start with your occupational therapist.
Wonderful. All right. Well, thank you very much for participating in those questions and answers, and again for a very informative session. Heather, do you have anything further to add? Excuse me.
No, I just wanted to say thank you to Kirsty. That was wonderful. I learned so much stuff. I think that the importance of the giving the medications on time just came through one more time. We've talked about this as a theme of all these sessions, and you just so realize what a difference it makes when the medication wears off. So thank you. I really appreciate your time, Kirsty. It was great.
Thank you. And again, my contact information is on the slides, so if folks have any specific questions, definitely get in touch with me. I do have a million roles right now, so I will apologize in advance if I don't get back to you right away, but I will get back to you. So definitely get in touch if you're interested.
And on that note, a final thank you then for your valued time, and to everyone who was able to join us today. We hope you found it useful. We hope you'll stay in touch. To Heather, thank you again, as always, for having the RNAO involved in this. And we'll see you all next time on the 26th of February. You'll see some notes coming out about that. We're going to talk non-motor symptoms of Parkinson's. Otherwise, thank you again, and enjoy the rest of your day.